A very
Donna, you want, it doesn't matter. If you want me to do it, I'm happy to.
yes. I'm gonna let you take the lead.
All right. Do I need to wait until 39 weeks to induce? And go to the next slide. We're finishing up, we're wrapping up our discussion on management of diabetes in pregnancy. And it's been a long jaunt to get here to finally to the delivery part. We talk about delivery a lot and when to deliver, and we're trying to keep most of our deliveries to 39 weeks or more. But this is a group of patients that will frequently need to be delivered early. Um, and one of the hardest things that, and Dr. Johnson and I both have agreed, one of the things that changed with the latest ACOG committee opinion on this was that they moved the gestational age to 36 weeks in uncontrolled diabetics. And there's no question that some should be delivered sooner than that. So we'll talk about that as we go. We know elective inductions, purely elective, shouldn't be done prior to 39 weeks. Those are healthy, low-risk moms. It does not apply to patients with other medical complications. So gestational diabetes, as we all know, several categories of these patients. The diet controlled typically means that they're well controlled. They can be delivered at 39 weeks or beyond. We typically don't recommend going past 41 weeks gestation, and your decision on when to deliver them, whether to deliver at 39 weeks or let them wait for spontaneous labor, can be guided by baby's estimated fetal weight, as well as whether we think they're being truthful with their blood sugars. Next slide. If you have a gestational diabetic on medication and they're well controlled, delivery at 39 weeks or beyond is very appropriate. But if they're poorly controlled, that is, one of their blood sugars or significantly elevated over our target range, induction between 37 to 39 weeks is very appropriate, and antenatal testing should be performed twice weekly on these patients that are on medications. Next slide. So with type 2 diabetics, same thing holds. If they're well controlled, you can wait a little bit later for delivery, but generally we say 38 to 39 weeks. If they're poorly controlled, we ratchet that down to 36 to 38 weeks, and that's based on both medical complications in mom, whether they have any evidence of vasculopathy, whether their A1Cs are elevated, or whether they're going up, and we have many patients that continue to rise with their A1C during pregnancy. If you have suspected large for gestational age or an increase in the amniotic fluid, those are other reasons to suspect either poor control or increased risk for the baby, and thus delivery a little bit earlier. Next slide. So type 1 diabetics, these patients are at a little bit higher risk because of the vasculopathy that typically goes along with type 1 diabetes. And even if they're well controlled, we typically will move those gestational ages a little bit earlier for delivery, 37 to 38 weeks. If they're poorly controlled, this is one of the areas that I disagree with the recent ACOG technical bulletin. There are patients in this subset that should be delivered earlier than 36 weeks. The newest bulletin suggests 36 to 37 weeks, but again, with consultation with maternal fetal medicine, I think that in some of these patients needs to be earlier, especially those who have significant vasculopathy, whether that be retinopathy, renal disease, heart disease. If we see continued elevation of their A1C in spite of our attempts to control their blood sugars, large baby polyhydramnios, and these patients need twice weekly antenatal testing as well. So if you have any abnormal testing, that might indicate the need for earlier delivery. Now, estimated fetal weight, remember, I tell everybody this, we're not perfect with our estimates. I like to tell patients that we're 10 to 15% off with our ultrasound estimates. We typically, and the ACOG technical bulletin does go along with an estimated weight greater than 4,500 grams to offer a C-section. I will say many practices will ratchet that down to 4,000 grams in a diabetic. I don't necessarily disagree with that, but I think you have to be very careful when you talk to patients about offering C-sections for weights less than 4,500 grams in this diabetic population. And prior to delivery, assess the pelvis, document, talk to them about their estimated fetal weight. And it's very important, particularly in so many of these babies, the abdominal circumference is so much larger than the other parameters in these baby sizes, that it's very important to talk to them about the potential for shoulder dystocia. I'll be curious to hear what you say, Donna and Dr. Nager. In patients who desire cesarean section at lower estimated fetal weights, we certainly do elective C-sections for far less well-documented reasons, and this is a group of patients that might deserve that. If you do encounter a shoulder dystocia, we talk about this all the time in our SIM coaches and in our education seminars. Document it well. Document that you've talked about it beforehand, and talk about it very carefully in your delivery note, and make sure that the nurse's notes and the physician notes are corroborated together. So do a huddle before writing those notes to make sure it's appropriately documented. Donna, any other comments about any of the things that we've talked about there with the...
Well, I mean, I think everybody on the call knows that we're not inducing large babies to, quote, prevent macrosomia. We're inducing large babies to try to prevent an IUFD, because it's the larger babies with poly that we can run into problems with. And I agree with you, Barry, about the 4,000 grams. I meant between 4,000 and 4,200 grams. If you read the literature, there is enough literature to support 4,000 to 4,200 grams, but the big issue is the estimated fetal weight, as you talked about, and I talk to patients about that. We call it estimated fetal weight for a reason. We don't have a scale on the inside that we can actually weigh these babies. We wish we could, but we can be off. You know, I say up to 20%. And that can affect, you know, their potential for a vaginal delivery when we've done a cesarean section. And the only other thing I will say is if I'm counseling a patient about a C-section, I also talk about the future risk of the C-section.
Very good point. Rachel, we've had several people join us. Do you want to go back to that?
Yes.